Hello, my name is Han Keunen. I'm an assistant professor of obstetrics and gynecology at the University of Toronto, and I work as a maternal fetal medicine specialist at Mount Sinai Hospital here in Toronto. And today we're going to talk about hemolytic disease of the fetus and newborn. I have no conflicts of interest. The learning objective of this talk is designed to meet the following end-of-week objective. Describe the pathophysiology of rhesus sensitization, fetal outcomes, and management principles. By the end of this module, you should be able to describe the definition, diagnosis, management, and prophylaxis of hemolytic disease of the fetus. Describe the pathophysiology of rhesus disease, its prevalence, and diagnostic tools to identify women at risk. And describe the maternal and fetal surveillance in rhesus-negative women and prophylaxis strategy. Well, let's start at the beginning. What is hemodynamic disease of the fetus and newborn? What are the characteristics and pathophysiology? This disease came with many names until it was defined as such. So old names are Icterus gravis neonatorum, and that is depicted by the jaundice that were often seen in these babies. Hydrops fetalis, or the waterlogged swollen babies that were often stillborn, and severe anemia of the newborn. What all these fetuses had in common was an abnormal blood smear. And when you look at the blood smear of the fetuses, you saw these very young erythroblasts. And that signified that there was an increased erythropoiesis based on the perceived hemolysis. Now, what can hemolysis ultimately result in? In the fetus, it can result into anemia. And when the anemia is severe enough, you might see severe hydrops of the fetus, as you can see on the left picture. So on the left picture, you see a cross-section through the fetal chest, and you see the severe skin edema outside the ribs. You see the heart in the center of the chest, and pleural effusion, or a water accumulation between the lungs and the ribs. In the newborn, hemolysis ultimately leads to waste products of hemoglobin called bilirubin. And this bilirubin will accumulate in tissues such as the skin. And these babies look quite yellow, are jaundiced. Now, what is the crux of the problem? Why does hemolysis occur? It occurs because of these immunogenic surface antigens on the red blood cells of the fetus, and the mother making antibodies against the antigens. These antigens ultimately are responsible for your blood type. Now, we all know the ABO and rhesus positive and rhesus negative blood type, but there are over 50 blood types or surface antigens identified. And these are a few common ones. And some of these can result in hemolytic disease of the fetus. The most important one is the rhesus antigen, which you will see in the middle. Do you know your blood type? When you ask for your blood type, often people say, I'm O positive or A negative. And the letter that is used is referring to the ABO blood type. And the plus or the minus or the positive or negative refers to the rhesus or D blood type. Let me explain a little bit about the ABO blood group system, because it demonstrates a lot about the other blood systems as well. So when you are blood type A, you have A antigens on the surface of your erythrocytes. If you're blood type B, you have B antigens on the surface of your erythrocytes. If you're group AB, you have both. And if you have group A, you neither have A or B. When you have group A, you have anti-B antibodies in your blood. When you have group B, you have anti-A antibodies. No antibodies in group AB, and both anti-A and anti-B antibodies in group O. Now look at how the antibodies look under group O. These are IgG antibodies that can cross the placenta. The antibodies in anti-B and anti-A in group A and B respectively are IgM antibodies, which cannot cross the placenta. The most common form of hemolytic disease in the newborn is OA or OB antagonism, where the anti-A antibodies in group O cross the placenta, but often this does not result in severe anemia in the fetus, but it causes hemolysis in the newborn and causes jaundice. Let's look at another blood type. Before we do that, I want to tell you a little bit more about how we make these blood types. We make these blood types because they're coded on genes. And that's true for the ABO system, and that is also true for the rhesus system. We always have 2 copies of the genes that code for the blood types, so-called alleles. And if you have an A gene on one allele and another A gene on the second, your blood type ultimately will be A. If you have an A gene coded on one chromosome or allele and no A nor B gene coded on the other, you still have A. So A plus O makes A. And the same goes for the B blood types, AB and the OO. In the rhesus system, if you have a D antigen on one allele and also a D antigen on the other, you're rhesus positive, or big D. If you have big D on one allele and no D or small d on the other, you're still rhesus positive. If you have no D antigen on one nor on the other, so small d and small d, you're rhesus negative. And I will focus now a little bit more on rhesus negative prevalence and rhesus disease, because that is the most common form of hemolytic disease in the newborn. So what is the rhesus negative prevalence? Rhesus negative blood type is more common in Western countries, and the incidence in Caucasians is up to 20%. So you have about a 1 in 5 chance, if you're Caucasian, that you're rhesus negative. The incidence of all negative allele carriers, so even if you have only one small d or one allele that is rhesus negative, is about 40%. So 40% of us will carry approximately at least one rhesus negative allele. The odds that a rhesus negative mother carries a rhesus negative fetus is therefore approximately 30 to 40%. Now, which moms are at risk for rhesus disease? The mother that's at risk for rhesus disease is a mom who is rhesus negative and whose partner is rhesus positive. Now, if the partner is homozygous, means he has a big D on each allele, the fetus will be rhesus positive in 100% of cases. If the partner is heterozygous, the fetus is rhesus positive in 50% of the cases, because the father can either give the small d or no big D or a big D to the fetus. Now, what is the pathophysiology? How do we get ultimately rhesus disease? Again, we have to start with a rhesus negative mother who conceives a baby with a rhesus positive father. Let's, for argument's sake, that this father is homozygous, so the fetus is for sure rhesus positive. So the rhesus negative mother is carrying a rhesus positive fetus, and blood of the fetus will cross the placenta during pregnancy at some point, and then particularly during delivery. Now, this is not a problem for this particular fetus, but it will be a problem for future pregnancies. Because what happens is that the immune system of the mother will recognize the red blood cells of the fetus as foreign and will start to make antibodies against rhesus positive blood. These antibodies will stay with the mom, and when she becomes pregnant again of a rhesus positive child, these antibodies can cross the placenta from mother to fetus. Once they cross to the fetus, these antibodies will link to the rhesus positive blood or rhesus positive red blood cells, and then macrophages can catch these sensitized and covered red blood cells and result into extravascular hemolysis, leading to anemia and possibly jaundice after birth. Now, if we want to prevent this problem from happening, we have to prevent this sensitization. Because again, the mixing of the blood from the fetus to the mother can happen at any time in pregnancy, and particularly at delivery. Now, we can prevent this disease from happening by giving exactly the same antibodies passively to the mother, and by doing so, we prevent the exposure of rhesus positive antigens on the red blood cells of the fetus being exposed to the maternal immune system. So the maternal immune system will not recognize those red blood cells anymore as foreign, and hence will not mount an immune reaction and producing antibodies. Sensitization occurs without prophylaxis in about 16% of cases, and with prophylaxis in about 0.1% of cases. So by giving the prophylaxis, 99.9% of women will not be sensitized. So how do we manage the rhesus negative patient without rhesus antibodies? To answer that question, we have to first establish that there are no antibodies present. And how do we do that? We do that by the very first blood test in pregnancy, which is a group and screen. The group refers to establishing if the mother is AB or O, and rhesus positive or negative. And the screen refers to a test that detects if the patient is carrying any antibodies against red blood cell surface antigens that are foreign to her. For example, anti-D antibodies, or antibodies directed against rhesus positive blood. When am I supposed to give the rhesus immunoglobulin, and how much? First, we have to establish that the patient is not already sensitized. If the patient is already sensitized, there's no point in giving RhoGAM or rhesus immunoglobulin. And subsequently, we have to see if the father is not rhesus negative or the fetus is rhesus negative. If the fetus is rhesus negative or the father is rhesus negative, then for sure the fetus will be rhesus negative, and there's no point in giving rhesus immunoglobulin. Routinely, we give RhoGAM or rhesus immunoglobulin at 28 weeks if the screen is negative at that time, and after delivery within 3 days of birth if the newborn is rhesus positive. In addition, we give rhesus immunoglobulin anytime in pregnancy when fetal maternal hemorrhage can occur. So when the mixing can occur. And this can occur in the first trimester after a miscarriage or after an ectopic pregnancy, or if I'm doing a chorion villus biopsy or amniocentesis for diagnostic purposes, after a blunt abdominal trauma, or if we try to manipulate the baby into a cephalic presentation, or if we suspect that there was a massive fetal maternal hemorrhage. How much are we giving? Well, it depends how far you are in your pregnancy. If you're further than 12 weeks, we will give 300 micrograms. And if you're less than that, so let's say after a miscarriage, before 12 weeks, we give about 120 micrograms, because the volume of red blood cells or the volume of fetal blood is obviously much, much lower at that gestational age. After delivery, we routinely also perform a Kleihauer-Bethke test or flow cytometry to quantify how much fetal blood ended up in the maternal circulation. And then the lab will inform you if the fetal maternal hemorrhage is more than 30 milliliters, and if that is the case, you will need more RhoGAM or rhesus immunoglobulin. So how do we manage a rhesus negative patient throughout pregnancy? We first look at the paternal rhesus phenotype. If that is rhesus negative, you're off the hook. Then at 10 weeks, at the first prenatal visit, we do a group-in screen. And we repeat the group-in screen at 28 weeks. And if that screen test is negative, we administer the first dose of rhesus immunoglobulins. And we do the same after birth if the baby is found to be rhesus positive, because that still needs to be established. How do we manage the patient that is rhesus negative but has rhesus antibodies? First, we have to quantify those antibodies. So we know that they're there, but now we have to know what the approximate concentration or titer is. And you establish the titer by diluting stepwise the original sample. So as the number goes up, the dilution gets stronger and stronger, and at some point the reaction will become negative. If the rhesus D antibody titer is less than 1 in 32, you can still follow the patient without any intervention, but repeat the titer every 14 days, as titers lower than this rarely cause hemolytic disease of the fetus. If the fetus, if the titer is found to be more than 1 in 32 or higher, then the fetus is at risk for fetal anemia. And the next step is then to refer the patient to me, the maternal fetal medicine specialist. So what do I do in step 2? Well, I know that the mom is rhesus negative, that the baby likely is rhesus positive, and that there are antibodies there that likely result in fetal anemia, or possibly. So what I now try to establish is if the baby is anemic. And I can do that with ultrasound. So with ultrasound, what I do is I do a Doppler of a certain vessel called the middle cerebral artery, or MCA Doppler. And the Doppler establishes how fast red blood cells flow through that vessel. The speed at which blood flows is a proxy for how thin or how thick the blood is. So if you're anemic, your blood is thinner and will flow faster. So the higher the peak systolic velocity, as we call it, the maximum velocity, is, the more likely it is that the baby is anemic. If we find that the speed is quite high, it is worthwhile to take a fetal blood sample and prepare for a transfusion. And we do this under ultrasound guidance percutaneously with a needle. And the needle is inserted either in the intrahepatic vein in the abdomen of the baby or in the cord root, as depicted here on the graph. 10% of sensitized moms with increased titers ultimately require an intrauterine transfusion, or IUT. The complication rate is about 3%, so you have to prepare for emergency cesarean section if the baby is at a viable gestational age. Intrauterine transfusions are done every 2 to 3 weeks until 36 weeks, and ultimately the baby is then delivered by 38 weeks if everything goes well. Now you might wonder, why do I need to transfuse again and again? Well, the baby stops producing these rhesus-positive red blood cells because the transfusions will downregulate the erythropoiesis, so it becomes reliant on these transfusions. And here you see a graph of the mid-cerebral peak systolic velocity of a patient throughout pregnancy that required 3 transfusions. At 20 weeks, everything was fine, and it remained so up until 28, 29 weeks, as you see an increase in the peak systolic velocity, prompting us to do a fetal blood sample. And lo and behold, the hemoglobin was 38 grams per liter. Anemia. During that same sample, we transfused through the same needle blood to the baby, and the baby had subsequently a normal blood count, and thereby reducing the peak systolic velocity. And a few weeks later, we saw the peak systolic velocity increase again. Again, the hemoglobin was now 93, and transfused again, and so on and so forth. So far, rhesus disease, but I want to give you one slide about another antigen, surface antigen, called KEL. As an obstetrician, you often learn the mnemonic KEL kills. So KEL, surface antigen, can cause hemolytic disease of the fetus and can cause in all the same features, but it's slightly different than rhesus disease. In rhesus disease, we know that you are sensitized after pregnancy and that this will lead to hemolysis. If you look at the blood smear, there are a lot of young red blood cells because the erythropoiesis goes into overdrive, so there is reticulocytosis. After birth, because of the breakdown, the hemolysis of the red blood cells, a lot of hemoglobin will be broken down as well, which will lead to a high level of bilirubin in the blood and in the tissues, ultimately leading to jaundice. And of course, it leads to anemia. Now, KEL works slightly different. First of all, KEL, or big K, is a minority of the population that carry that gene. So 90% of the population is actually small k, or KEL negative. The sensitization happens after particularly a transfusion of blood, not so much after pregnancy. And if you look at where KEL antigens are expressed, you will notice the difference that KEL antigens are earlier expressed in the developmental pathway of the red blood cell. So they are particularly expressed already in the bone marrow in the proerythroblast. So you can imagine that these antibodies will have an effect on the bone marrow. No hemolysis will occur there, but you will get a bone marrow suppression that will dry up the erythropoiesis and therefore will lead to a reticulocytopenia, or a lack of young red blood cells. This can ultimately lead to anemia. And another distinctive feature is that the titers are not as predictive as the titers in anti-rhesus disease. So in those patients, we particularly go by ultrasound only. So how to conclude this talk in one slide? When you're confronted with a rhesus negative mom, first ask what the rhesus type of the prospective father is. If the father is rhesus negative, there's nothing to worry about, but you're still going to do a group and screen at 10 weeks of gestation at the first prenatal visit. If there are no antibodies, you will follow that patient routinely and repeat the group in SCREAM at 28 weeks and administer rhesus immunoglobulin if the father's rhesus is positive. Subsequently, you will repeat the RhoGAM or the rhesus immunoglobulin after the delivery, after it's established that the newborn is rhesus positive. What if you find antibodies, which is depicted in the red? So if I find these anti-D antibodies at the first visit, I will have to repeat those titers every 2 to 4 weeks and refer the patient if those titers start to increase at or above 1 in 32. And then we will take over with Doppler ultrasound and maybe do a transfusion every 2 to 3 weeks, depending what the findings are. After birth, the pediatrician will take over, because as I said earlier, jaundice and hemolysis will continue into the neonatal period. I hope this summarizes this talk well for you, and I hope you enjoyed the slides. So the module objectives are that by now you should be able to describe the definition, diagnosis, management and prophylaxis of hemolytic disease of the fetus. Describe the pathophysiology of rhesus disease, its prevalence, and diagnostic tools to identify women at risk. And describe the maternal and fetal surveillance in rhesus-negative women and prophylaxis strategy.